So today we are discussing module 14, that is endocrinological disorders in the elderly. And when we jump into these topics, it requires you to have basic understanding of the endocrinological functions. Now, whenever you talk about the endocrinological functions, you are aware that there are hypothalamic, pituitary, and then other organ, the other endocrinological organ cycle or axis. So when we talk about elderly, it is something with senile changes which is going to be there. These senile changes, especially the calcification, is going to affect lot of secretions and feedback pathways. So feedback pathways are usually chemical mediators, but the secreting organs itself have been calcified. There has been a lot of mutations because of the life. We need to, our goal is to explore those clinical guidelines, those pathophysiology, and most importantly, those genetic and geriatric nuances that is going to differentiate the normal population, normal uh, aging population, senescent population from the actionable pathology. So we will see to de-prescribe, okay? De-prescribe. They are already on many medications, okay? They have to have sometimes tight
Endocrine
control.
disorders are common but often overlooked in the elderly. Aging affects hormone balance across multiple systems. Diabetes is one of the most prevalent conditions. Thyroid dysfunction can impact metabolism and energy levels. Hormonal changes weaken bones, increasing fracture risk. Adrenal issues may present with fatigue and low blood pressure. Early diagnosis helps prevent serious complications. Proper management improves quality of life. Timely care supports healthier aging. Stay informed to manage endocrine health effectively.
2.5. So I can get 97.5th percentile of TSH reference limit, and that will be a perfect normal value for my age. Okay. So, and what if they truly have subclinical hypothyroidism? Say their TSH is 7.5. Do we treat them or not? So the definitive answer comes from the trial. Okay, we will see them. The trial is called as TRUST trial. Thyroid hormone replacement for untreated older adults with subclinical hypothyroidism. Okay, so this TRUST trial, okay, the data is very clear. In older adults with a TSH between 4.6 to 9.9, levothyroxine provides absolutely no symptomatic cognitive or cardiovascular benefit. Routine treatment is not indicated or recommended if the levels are between 4.6 to 9.9. We typically only consider treatment if the TSH persistently exceeds 10 milli international unit per liter, or if there is TPO antibodies which are highly positive, okay, in higher titer itself, okay, or if there is undeniable severe symptomatology, high symptomatic burden is present, okay. So then you have to start levothyroxine 12.5 to 25 microgram, start at the low doses, and you can escalate to avoid any atrial fibrillation or angina. Okay. So conversely, let's look at the hyperthyroidism. So far you have seen the hypothyroidism. And hyperthyroidism,
Not all hyperthyroidism looks hyper. We are introducing the condition known as apathetic hyperthyroidism, commonly seen in older adults. Instead of the typical anxiety seen in younger patients, they present with fatigue. Patients often experience significant and unexplained weight loss. Many also present with depression-like symptoms and withdrawal. They frequently report profound fatigue and muscle weakness. Hidden clue? Atrial fibrillation. This condition is often missed during the initial diagnosis. Thyroid tests reveal the truth. Early recognition and treatment of this condition is critical.